Welcome to this explainer. You know, when a patient presents with a bleeding airway, there is literally no time for second guessing. You need a comprehensive, ordered approach. So today, we're going to break down the definitive 2026 emergency management algorithm for post-tonsillectomy hemorrhage, or PTH. We're going step by step, strictly by order, mapping out exactly what you need to do and precisely when you need to do it.
But before we jump into the algorithm itself, let's get our timeline straight. We're primarily dealing with secondary hemorrhage here. This unpredictable bleeding usually strikes right when the patient is at home recovering, most commonly between postoperative days 5 and 10. Because it happens off-site, patients usually arrive at the ER highly anxious, meaning your team has got to be ready to act immediately.
All right, let's move through this algorithm strictly by order. 1. Triage and primary survey. 2. Assessing severity and TXA. 3. Resuscitation and local measures. 4. Operative hemostasis and theater. And 5. Postoperative care and discharge.
Section 1. Triage and primary survey, the first critical minutes. The golden rule here is stark and absolute. Any history of fresh bleeding after a tonsillectomy is a strict ENT emergency. You do not wait around. You immediately notify the senior ENT and anesthesia teams. The situation can deteriorate incredibly fast, so early senior involvement is, well, it's absolutely essential to a good outcome.
Your strict ABCDE primary survey proceeds sequentially. First up, keep the patient NPO, sit them upright to help protect the airway from blood pooling and get continuous monitoring going. Step 2, visually assess the airway for active bleeding or clots while prepping for a difficult airway scenario. And finally, Step 3, manage breathing and circulation with high-flow oxygen, 10 to 15 liters per minute, and definitively secure access with 2 large-bore IVs.
Concurrently with securing that IV access, you gotta draw your blood work immediately. We're talking full blood count, U&E, coagulation screens like PT/INR and APTT, and crucially, a group and save or full cross-match. If the bleeding is severe, make sure you check fibrinogen levels too. You're establishing the patient's baseline here and getting your team ready for potential major transfusions if things go sideways.
Section 2. Assessing severity and TXA. Methodical stabilization.
Okay, the crucial next step is accurately categorizing the bleeding, because this dictates your entire intervention. A minor bleed? That's just blood-stained saliva in a hemodynamically stable patient. A moderate classification means you're seeing an ongoing ooze, a visible clot, or recurrent bleeding. But a major bleed is an immediate red alert. We're talking active arterial bleeding, hemodynamic instability, or any airway compromise. You absolutely must know exactly where your patient sits in this matrix.
Now, if you remember just one number from this explainer for immediate pharmacological management, make it this: 1 gram. 1 gram is the definitive adult IV dose of tranexamic acid, or TXA, to help stabilize that clot formation.
Obviously, dosing builds based on demographics and routes. So while adults get that flat 1 gram IV, children require a carefully calculated 15 milligrams per kilogram IV, capping at a maximum of 1 gram. Alongside IV access, nebulized TXA is a real game-changer as a vital adjunct while you prep for definitive management. Adults can get 500 to 1,000 milligrams nebulized, while kids get 250 to 500. This local delivery can literally buy you precious time.
Section 3. Resuscitation and local measures. Managing the bleed.
Your resuscitation has to start systemically with balanced crystalloids. And hey, if the patient is bleeding rapidly and shifting into that major category we just talked about, do not hesitate to activate the major hemorrhage protocol. Using the blood work you drew in Step 1, you now need to actively correct any identified coagulopathy, thrombocytopenia, or hypofibrinogenemia. You are essentially rebuilding the blood's ability to clot.
Now, there is a very strict clinical boundary for bedside measures. You can apply gentle suction to clear your view, and if the patient is cooperative, you can carefully apply adrenaline-soaked swabs directly to the tonsillar fossa. But listen, you must explicitly avoid aggressive clot removal outside the operating theater unless absolutely essential. Digging around blindly on the ward is a surefire way to restart catastrophic arterial bleeding, and nobody wants that.
Section 4. Operative hemostasis and theater. Definitive action.
I really want you to keep this key clinical pearl firmly in mind. A clot in the tonsillar fossa predicts rebleeding. I'll say it again. A clot predicts rebleeding. Even if the active dripping has stopped, the mere presence of that dark organized tonsillar clot is a massive warning sign. It's just a temporary plug on a compromised vessel, and the hemorrhage is highly likely to return. Because of that, relying on conservative treatment isn't always going to cut it. If you see active bleeding, recurrent bleeding, a large clot with a history of recent bleeding, hemodynamic instability, airway compromise, or just a general failure of bedside measures, you're done on the ward. Surgical intervention under general anesthesia is definitively required.
Once you've got the patient safely in theater, the surgical hierarchy proceeds in a specific order. Bipolar diathermy is your preferred, most common method for achieving hemostasis. If that doesn't do the trick, you move to alternatives like suture or vessel ligation. And finally, for the most stubborn, refractory bleeds where surgical control completely fails, you've got to escalate to endovascular embolization by interventional radiology.
Section 5. Postoperative care and discharge. Vigilance and recovery.
Just because the patient is out of theater doesn't mean they're out of the woods. You have to rigorously monitor their vitals, recheck that hemoglobin if there was significant blood loss, and honestly, watch like a hawk for rebleeding. Crucially, the 2026 guidelines enforce a minimum 12 to 24-hour in-hospital observation window even for minor bleeding events, and a significantly longer stay following a major hemorrhage.
Finally, when the observation period is completely clear, discharge requires strict patient education. Before they walk out that door, empower the patient and their family with crystal clear instructions. They need to know to return instantly if they experience any of these specific red flags: any fresh bleeding whatsoever, spitting up blood clots, difficulty breathing, dizziness, or syncope. That last one is huge because it could indicate a hidden swallowed bleed causing hypovolemia.
As we wrap up this explainer, I want to leave you with one paramount rule from the 2026 guidelines. A history of bleeding is significant even if no active bleeding is seen. Never, ever dismiss a patient's reported history of bleeding at home, even if their throat looks perfectly clear when you examine them in triage. The clot might have been swallowed, or the vessel might have temporarily spasmed shut. Treat their history with the utmost respect.
So ask yourself this. Considering secondary hemorrhage most commonly strikes unpredictably between days 5 and 10, are you fully prepared? Because when that unpredictable bleed hits your department, your ability to execute this exact chronological sequence could literally be the difference between life and death. Memorize the steps, follow the algorithm by order, and stay ready.